Sheena Gosain, take one.
Oh.
Okay, go for it.
All right, so Ray's already introduced. Oh, I think there's a question from before.
Hi, yeah. No, I was just wondering, for Marion Print, for printing our poster, there's a specific size that allows a discount. Do you remember what size that was?
36 by 48.
36 by 48?
It's a crowdfunding question, isn't it?
All right, so my name's Sheena. I'm a current master's student at the University of Ottawa. I'm just finishing up my thesis, like Ray mentioned. And so I'm kind of feeling this out with you guys, but I've kind of added some extra stuff in to hopefully give you some more context into what I've done and some different applications of FE and not just your traditional quantitative methods. So my thesis was on how we make drug reimbursement decisions for drugs for rare diseases. So that might sound like a lot or really confusing right now, but hopefully we'll walk you through it a little bit and help you understand what that's all about. All right, so I just want to start by acknowledging my thesis supervisor, so Dr. Doug Coyle here at the University of Ottawa, Dr. Tammy Clifford at the Canadian Agency for Drugs and Technologies in Health. I'll talk a little bit about that in my presentation, but also maybe afterwards. And then Barry Jones at Health Canada. I also want to acknowledge the funders of my thesis work. So my project was funded by a CHR team grant held by researchers across Canada, looking at different policy-related issues with orphan or rare diseases. So I just want to step back and talk to you a little bit about drugs in Canada. So for drugs to be able to be for sale in Canada, they have to be regulated. And so the first step is to go through the regulatory process, which is done in Canada by Health Canada. It's similar in other countries, but I'm just using Canada as the example. And so Health Canada looks at the safety, the efficacy, and the quality of drugs. So that's mostly based on clinical trial evidence, usually provided by the drug manufacturer. But beyond that, we have to wonder who's going to pay for these drugs. So once a drug is available for sale, it doesn't necessarily mean that it's accessible. So in some cases, patients pay for drugs. Sometimes it's private insurers. So that would be the category that most of us would fall in. So if we went to the pharmacy and got something, either we'd pay for it ourselves or our insurance companies would. But in some cases, you might be covered through a public drug plan. So in this case, it's funded by the provincial or federal government, mostly provincial because our healthcare is provincially funded. And so I'm just going to use And so when you make funding decisions, the things that you look at are different than what is looked at in the regulatory process. So I've kind of lumped things into three different categories of what's considered when reimbursement decisions are made. So first, it's clinical evidence. So that's looking at effectiveness. Do you all know the difference between efficacy and effectiveness? Anyone? No? Okay. So efficacy is really what comes from clinical trial evidence. It's whether the drug works or not. But effectiveness is the real world application of the drug and how it works in practice. So it's how well it works. So that's one of the really big things that's looked at in reimbursement that's not exactly covered in the regulatory process. But also we look at economic evidence. So economic evidence looks at the cost effectiveness. So whether the drug provides good value for money. I think you might have done a little bit of health economics in this class, no? Not really this year? Okay. So health economics looks at whether it provides good value. So if a drug is really expensive and works really well, then maybe we should fund it, maybe we shouldn't. And if it doesn't work very well and is really expensive, then we probably shouldn't pay for it, for example. But there's also a lot of other things that policymakers need to consider. So they look at different social factors and also different political factors that help guide their decisions about which drugs to fund and which drugs not to fund. Because we only have so much money, so we have to be able to figure out how best to spend it. And so I'm just using Ontario as an example of how it kind of works in Canada. So first, what happens is a drug is developed by a manufacturer and then it's regulated. And after that, if it's a new drug, it'll go through something called the Common Drug Review, which is done by CADTH. And what happens is it's submitted and they provide information about the effectiveness and the cost effectiveness of the drug. And then CADTH does a review And then a committee makes a recommendation for whether or not the provinces should fund this drug through their drug plans. And then the province has its own process. So once they have that recommendation, the province will look at that as well as any other province-specific factors. So such as drug pricing, because drug pricing is also different possibly across provinces. And then they will issue recommendations to the drug plan, and the drug plan will make the final decision. So the question here that I'm going to start to cover is whether or not these or similar processes have the same application in the context of drugs for rare diseases. So what are rare diseases? So rare diseases are conditions that affect a really small number of individuals in the population. But the definition isn't really very clear of what that means and changes across applications and across jurisdictions. So so it can range from 1 in 1,000 people to 1 in 150,000. So 1 in 1,000 actually doesn't sound all that rare, and so it's hard to work with a group of conditions where you don't even really have a clear definition. But also, even if they are really, really rare and only affect a few people, for example, in the country, collectively there are between 5,000 and 7,000 different rare diseases, and there's new ones being found every single day. So that collectively means that there's a pretty huge public health concern and a potentially large budget impact, which I'm going to get to in the next slide. And so drugs for rare diseases are the drugs that treat these conditions. You might have heard of them referred to as orphan drugs in other contexts. I try and stay away from that term because they're not actually that orphan anymore. They're still rare, but there's a lot of work being done in this area now. And so these drugs are a challenge because we don't know a lot about these conditions to begin with because they're so rare and they might be relatively recently found, and we don't know a lot about how patients progress through these conditions, and there's often misdiagnoses associated with them. So it takes a lot of time to fully understand the conditions, and we don't know a lot about that as of yet. But also, in the drugs that are developed, we don't know a lot about the clinical effectiveness and safety of these treatments because clinical trials can't necessarily have the same number of people because you have so few people to work with. But also these drugs come at a huge cost in many cases. Not always, but in many cases, these drugs are extremely, extremely expensive. So the example that I used is L-glucosidase alpha for a treatment of Pompe disease. It was actually on a House episode if you guys want to look it up. So it's $44,000 to $88,000 per patient per 5 to 10 kilos. So that's actually over $200,000 per patient per year. And that's not even the most expensive. This is actually probably more like a mid-range rare disease drug. And so these drugs have high costs and high uncertainties, so we start to question whether or not the processes that we use now are as applicable in the context of these drugs as they are in the drugs that we evaluate regularly. So often what happens is that policymakers are forced to make these decisions based on social and political factors, and often that ends up in a positive funding decision. Or the drug is never evaluated through a mechanism like the one that's traditionally used. And so this presents a pretty big problem, and it's something that we should look into fixing, especially as more of these drugs begin to become available. So that's where my thesis work comes in. So I have 3 different things that I covered in my thesis. And so the first one was to look at whether we can really justify having a different process for drugs, for rare diseases versus drugs for common diseases. Because everybody should be, in theory, entitled to whatever drugs that they need, and we should evaluate them all equivalently, but is there a reason we should be considering them differently? Maybe there is, and so just looking at different ethical concepts, looking at whether we can justify having a different process, not necessarily looking at whether we should justify one-off decisions or justify different criteria, but a different process altogether. And then the second part, what I did is I looked at what is currently being done I used the G20 countries as well as Canada as a sampling frame to look at what's currently being done in different areas for making reimbursement decisions for rare diseases. And the last part, I did a couple of case studies to look at what funding decisions result from the application of different processes. All right. So for the first part, like I mentioned, it was to look at different ethical principles to determine whether or not we can justify having a different process for drugs for rare diseases versus drugs for common diseases. And so what I did is I did a conceptual analysis of potential rationale. So it was based on another work that was done in the area of end-of-life care, and then expanded to look at specific rationales that have been presented in the context of drugs for rare diseases. So the next slide is just the concepts that I looked at. I'm not actually going to go into any of them in any detail because it's a lot of bioethics and it's a lot of discussion that's quite interesting, but it's kind of a lot to go over in this class. So if you guys have any questions about it, you can bring it up to me later. But so I systematically went through each of these to look at whether or not they would provide a reasonable reason to have a different funding process. And so based on that, I realized that there are three really key problems when we're trying to think of whether or not we should have a process, and each of these are subject to challenges. And so we know that if we want to allocate resources based on healthcare need, having a different process for rare diseases is not necessarily in line with that. And also, there's a lot of differences between rare diseases, and so there's a lot of heterogeneity in the rare diseases themselves. So some of these criteria might apply to them, but some of them don't. So if we're going to have a process, we should really have one that is generalizable to all rare diseases based on rarity. And also, the challenges present in rare diseases are often not unique to rare diseases. There are often the same concerns with some drugs for more common conditions. So there are common conditions that are really expensive. There are some that are really severe. There are some that also affect children. So if we're going to develop a process, then maybe it's changes to the process in general and not necessarily changes just for rare diseases. So the one exception to that was the differing evidence-based argument. So there is a differing evidence base for drugs for rare diseases, simply because you have so few people to work with that you can't conduct the same types of research necessarily. So you might have to apply different and innovative methods. And so that could be a reasonable reason to have a different process, but that doesn't mean necessarily that we have to change all the criteria. It just might mean that we have to look at specific things when we look at rare diseases and maybe allow for different considerations. And it doesn't justify different thresholds either. So, for example, in cost effectiveness, they often use thresholds for how expensive is appropriate. It doesn't necessarily justify allowing to spend more money here or not. So, all right. So the second part is where I go through the processes that are currently used in the G20 countries in Canada to give an international understanding of what is currently being done in this area and how it's currently being handled. So I started with the G20 countries as a sampling frame, as well as the Canadian provinces, and I did a critical review to identify processes that exist for drugs in general, as well as specifically for drugs for rare diseases. And I looked at the published literature and the gray literature. So a lot of gray literature, because most of these processes are done by health technology assessment agencies and government agencies. So it's not, so it's often not in the published literature. And so as of February 1st, 2014, there was 12 jurisdictions that consider rare diseases uniquely within their reimbursement frameworks. And that can mean either using different criteria or a different process altogether. So some of them just make special considerations within the process they already use, but some of them have fully developed processes only to look at rare diseases. And so this is what I just show you which ones are the ones that are considered rare diseases through their regular frameworks versus those that had specialized processes. And so Ontario and England are the only ones who have dedicated process, and the process used in England is actually no longer used as of after my review was over. So it's an evolving area. All right, and so in reimbursement decision making, often it's based on a framework that was developed by that looks at fairness, and in that framework, there are 4 different things that you would look at to have a fair reimbursement process. So you'd have relevance, transparency, a process for appeal, and then a way to enforce the process. And so for each one of the processes that I identify, you use this framework to evaluate, to critically appraise it. And so only 2 of the frameworks, I didn't actually include the enforcement criteria for the reason that I looked at agencies that not only made decisions, but also those that made recommendations. And so it's hard to separate enforcement when it's two very different objectives. So only 2 of the processes met all the criteria for relevance, transparency, and process for appeals. So that being said, the current processes for reimbursing drugs for rare diseases are evolving. And as a growing number of drugs for rare diseases are available for approval, we'll definitely need more processes that are fair and equitable. And currently, few jurisdictions actually have specialized processes dedicated for funding drugs for rare diseases, while some do make considerations within their current processes. Most don't have dedicated frameworks. The rationales used in these frameworks varied pretty widely, and it's important that they start to think about whether or not the rationale that they're using for a different process is justifiable. And a lot of the processes don't meet the criteria for fairness as outlined by the lack of relevance, transparency, and opportunity to appeals. All right, and so the last section I just did a couple of case studies, so I'll just go over those really quickly. It's kind of interesting to hear about the different rare diseases and kind of the context and look at what decisions actually were made. So I did 2 different case studies for 2 different rare diseases for the reason that to allow for some comparison, because both drugs are quite different and their populations are different and their costs are different. So the first one is the one that I used before. So it's Pompe disease, which is a lysosomal storage disorder. It has a prevalence of 1 in 40,000, and it's a multisystemic condition. And so the drug for this is the one that I mentioned. So you're looking at an annual cost of about $200,000 to $300,000 per patient per year. And so that drug was only reviewed by 8 out of the 29 processes that were included in my analysis. Only 8 of them reviewed this drug, and 6 of them gave the recommendation that it should be listed under restricted benefit. So this drug is effective, but in a certain subset of the population. So that's why it's been funded for restricted benefit. And usually they're special access because of their high cost, or they usually have pretty stringent criteria. And so I didn't actually talk a lot about HTA and health tech in general, but health technology assessment is oh my goodness, I'm losing my words. It's a process that's used to evaluate technologies, and what they do is they systematically go through the things that I went through earlier, the clinical evidence, the economic evidence, but also usually ethical and legal factors. And so there are agencies that do that, usually separate from government or in government, that are tasked with taking that on. And so I separated those out in my analysis, and that's why I have the results separately here for that. So 7 out of the 17 health technology assessment processes reviewed the drug, and all 7 gave a recommendation for restricted benefit. And in Canada, 7 out of 13 provinces provide this drug for restricted benefit. The second case study is it's called chiropractor-associated periodic syndrome, CAPS, from now on. It is a genetic condition that affects 1 in a million people in the US, so similar in Canada, they assume. And there are 3 different phenotypes of the condition which vary by severity. So patients with the first phenotype have much less severe symptoms than the third one. And so the effect to patients is really different, and the efficacy of the drugs varies by phenotype. And so this drug is also an enzyme replacement therapy, and it costs about $100,000 per patient per year. But again, it's weighted dosing, so it might also change by patients. Oh, sorry, repeated slide. And so in this case, this drug was reviewed only by 4 out of the 29 national funding systems, and only 1 of these recommended that the drug be listed for restricted benefit. And then in the HTA agencies, it was evaluated by 4 out of 17, and 2 recommended that it be funded for restricted benefit. And only 2 out of 13 Canadian provinces provide funding for this drug. Interestingly enough, it's 2 provinces that have processes specifically for evaluating drugs for rare diseases. And so based on this analysis, we know that different funding outcomes can come from using different processes. And also from across medications, the funding outcomes varies, likely based on the characteristics of the condition. But it's really hard to make a lot of concrete judgments based on this because there's so much lack of transparency in how decisions are made. So we don't actually know, even if there is a process, we don't know how rigorously they followed that process, and we don't have it documented how they got to their final decision. And so definitely more work needs to be done in the area of transparency to help us understand how different characteristics can influence the funding outcomes. And so next steps are definitely to look at the processes that we have now. And since we do know that there are things like the evidence base that vary for drugs for rare diseases, consider how we might change processes, or whether we should develop future processes. We should just keep in mind whether or not these are justifiable, and we should consider what's been done elsewhere to help inform the development of new processes. And definitely future processes should look at being more transparent and should, So that's all I have. So if you have any questions.
Questions? I have a question.
Oh.
So, for people who are new to this, obviously, what are the aspects of epidemiology you've used for this study?
So, a lot of searching. So did a lot of systematic searching of the literature and great literature. So, and then also, so you mean like in terms of epi methods?
Sure, whatever you like. I mean, people are probably wondering like what aspects of this relate to what they learned in class.
Okay, so I mean, one thing, it's like a really it's a public health issue, and so it has implications for at the population level. So the decisions that we make are important because they don't have an impact only on the patients, but also on the population as a whole. But also in terms of methods, so my second portion was a quasi systematic review, because I also can't call it a systematic review because I couldn't follow a strict protocol just given the type of literature that I was looking at. So as a result, it was like a really iterative search, but it tried to be very thorough and systematic in that sense.
Thank you.
Yeah. Okay.
Other questions? So there will be a question from this presentation on the final exam.
Oh my goodness.
Exactly, everything relevant. So one question only. Don't pay attention. That's it. Thank you very much.
Easy, painless.